Good evening, Professor. My name is Rodolfo. I'm a freelance researcher. I studied medicine, but I didn't finish it. But anyways, I have several questions actually. One of these things that really bugs me for a while, since the 80s, I studied poverty all over the world, including the US of A. How do we reconcile the 20th century scientific discovery, human government, and laws with the teachings of Buddha, Jesus Christ, Muhammad, and many others?
Okay, I'm sorry.
How do we reconcile
the
the scientific discovery of the 20th century,
yeah
human laws and government, with the teachings of Jesus
human,
Christ?
I'm sorry, I'm not getting the human
Laws.
laws
And government. LAW.
Oh, laws.
Yes,
okay,
forgive
laws.
my accent.
I
have
think I
several.
was hearing laws.
Forgive
okay.
my accent.
Okay.
But anyways, how do we reconcile that?
Yeah. Well, I mean, that's probably several books worth of a question. Again, I don't think that there is ultimately any sense in which if you have a unified theory of truth, that anything that we discover scientifically, refutes any sort of teaching, whether it's dogmatic or theological or ethical, about from any religion, any of the mainstream religions. I can speak, certainly for Christianity, if they're properly understood. Sometimes we have to move beyond, simplistic understandings of religion and beyond simplistic understandings of science in order to be able to reconcile those. But I don't think, in principle, there's anything about, about science, for instance, evolution, etc. I mean, that really can't ultimately be reconciled. So, but it's a huge question, and I'm sorry I can only give you a sort of very general answer to it. So.
Hello, my name is Jutta Hagner. I'm working on a doctoral degree in counseling, and when we have incurable patients, one of the aspects of that condition is that they have a lot of pain. And we may not necessarily be able to put all their relationships internally back together again. In that instance, is pain relief a healing act?
Yes. Well, that's a very good question with two parts to it. Let me first say that that medicine is a finite craft, even if it encompasses the spiritual, and we're not going to be able to always completely, restore all of the interpersonal and spiritual, disharmony in patients, let alone the physical aspects of a patient's healing. The way I've sometimes put this is that dying is never pretty, right? It can be beautiful, but it's never pretty. Right? And sometimes we have a naive view that we can always make it pretty. And patients will often die with their untied endings still untied, right? Including other aspects of their relationships with other people or with God. So we can do the best we can to open a space in which that person can address those questions of meaning, value, and relationship as they're dying. But we should not be so arrogant, I think, as to think that it's ours to correct them, right? It's only to point the way. The second part of the question relates to healing and pain control. Yes, absolutely. I think sometimes, particularly some of my fellow Catholics will say, I want to don't give me morphine. I want to unite my suffering to the suffering of Christ or something like that. And I try to remind them that it's really hard to pray when you're in pain, right? It just sort of takes over your consciousness, and in fact, morphine, when it makes a person who is in pain, whose consciousness has been taken over by that, if you give it in the right dose, gives them enough to be able to actually restore them, which is what usually is the case, then that person can engage in conversation, can engage in decision making, can engage in prayer, and they are in fact restored. And that's why, if you read in the Wisdom of Ben Sira, chapter 38, verses 1 to 15, in the physician's poem there, it says, God made the earth with healing herbs by which the doctor eases pain, right? So I think that that's very much that adequate pain control is very much part of healing for a person. And I don't want to draw too tight a distinction between the physical healing and the spiritual healing that can go on, because they ought to be all done simultaneously and they're interrelated.
Hi, my name's Kara Curtis. I'm a MDiv student here, but I spent the past couple of years working in a health research context, and so I know firsthand that there can often be a lot of hostility or just not wanting to talk about the spiritual side of things, and I think for reasons that go beyond just that I don't have time for it. I think sometimes it comes out of negative experiences, even in professional contexts. Like one of the researchers in my center is a reproductive health researcher, and is constantly under threat of being defunded. And so I'm just curious how in your work, you start to just bridge those gaps and just without being overbearing, just kind of start to invite the conversation.
Yeah, no, it's a great question. Again, I'll start with a little bit of poetry. I shared it with some of the folks this morning from Ezra Pound, a poem that says, "And she is dying piecemeal of a sort of emotional anemia. She wants desperately for someone to speak to her and is almost afraid that I will commit that indiscretion." Right? That I think that's the state I find. Sometimes it's a state that patients can be in, but more often it's a state that practitioners are in. I mean, they're human beings. They have questions about the meaning of their work, the meaning of their life. They have questions about their relationships. They have questions about their value as persons, and whether it all consists in getting the next grant, right? And am I reduced to that? And they know that they're more than that, and often are quite hurting. So I think the easiest ways to do it are, particularly in many of those cases, are with more of a soft sell, right? You just go in and sort of say, how are things? It's the same way I think is what's the best way for those of you who are chaplains know to, talk to a patient, or a practitioner to talk with a patient. When I, as a physician, am facing a patient who's got a very difficult time, I sit down and say, how are you doing with this, right? That's all you've got to ask. And I think trying to take the state of the physician scientist as a person, right, and reminding them that they're persons, and asking them questions as if you remind them by the question that they are persons, is the way to begin. It can be tough because sometimes people have built up such armor around themselves that it's difficult to get in. But I think that's the best way to do it. I wouldn't come in and start preaching or say read the Bible. It's reminding me too of a story from one of my philosophy professors who was Chinese and a convert to Roman Catholicism. She's from Hong Kong, and she said, people came to me and they bring the Bible. They say, you want to be, you read this Bible, you want to be a Christian. She said, I have no interest in reading the Bible. She said, Jesuits come to me, they say, come to party. I went to the party. Then they say, come to another party. Well, I came to another party. And they say, oh, we're having a big party. So, I come to the party. The next thing they say, read this book. And the next thing I know, I'm a Christian. So, I think that sort of way of being there. And for me, to be honest, as a clinician, being shoulder to shoulder with people really, really helps. So, my fellow physicians will come to me sometimes with questions about, marital problems in the Catholic Church, and sort of, because it's easier to talk to me than it would be to somebody who's wearing a collar, for instance. And so infiltration, soft sell, but being present to people and treating them as persons and inviting is the way to go.
Hi, I'm Paul Kaufman from Australia. I'm interested in psychiatry and religion, and I think already in the first century in Palestine and beyond there was a religious treatment of people with acute psychiatric illness. There was touch, as you were alluding to, and also the Greek language talks about pure spirit driving out impure spirit, but then Paul's talking about men and women, Jew, non-Jew, Gentile, highborn, slaves, all being equal and being a supportive community. So that presumably would help healing someone with an acute psychiatric illness in a religious context, but also the Greek physician Galen, who had wrote at least 30 books. He said if you've got an acute psychiatric illness, you should have a calming environment, exercise 1 hour a day, listen to the harp for 1 hour a day, listen to Greek tragedies and plays, and also make sure your slave massages you for 1 hour a day. Well, how good is that? You know, that must be helpful. That they also had some sort of basic pharmacology, so there was a scientific approach already by the first century as well as a religious approach. In the 1950s, some very interesting American psychiatrists who were also committed Christians tried to integrate their religious faith and beliefs in Christianity with their psychiatric practice. Do you know, apart from Duke University, but do you know anyone around Harvard or Boston who's a practicing psychiatrist and also interested in a research sense in integrating modern psychiatry with religion?
I'd invite people who are here maybe to answer that question. They might know it, know answers to that better. I don't, offhand know anybody. Michael, does anybody come to mind there, or no? Oh, yes, right, that's right, yeah, good.
So he's a professor in medical school, Berkeley, Harvard.
Mhm.
Dr. I can tell you after.
Good. Yeah, you'll find wherever you are, there's at least one person. There's somebody in a big university like this who's interested in these questions. And I just would reinforce what you're saying, that we have a lot to learn from people like Galen about, therapeutic communities, right? And so, good.
Just to echo a couple names, I'm Carrie Oxley. I'm a psychiatry
Carrie.
resident at Mass General Hospital. And yeah, John Petit has created a wonderful group for Christians who are psychiatrists and psychologists to gather and for conversation. Joanne Angelo is another name that stands out. She's a psychiatrist in the area and a faithful Catholic. And there are a few others, so you can connect with me afterwards.
Good.
And there's also Dr. Kleinman, who is here,
Mhm.
who's a psychiatrist and an anthropologist. He's a great resource that we put.
Good. A community. There you go.
My name is Krish. I'm a MD Psych from India and currently in MD. A question, if I have to look forward into a future, say 10 years from now, what would you see a program, a medical department of psych and spirituality? How did it look like?
Good question. I think that in terms of how it could be structured in healthcare, my best hope, and this is something I shared this morning with the palliative care group and more with the chaplains afterwards, is that the model of hospice and palliative care would be generalized to all of healthcare, right? Where the psychiatrist and the social worker and the nurse and the physician and the chaplain are all part of one healing team, right? And they work with each other and they respect each other and they reinforce each other's work. And I think that may come, because I think that the experiences of alienation from the medical system, which I think patients have been complaining about for several decades, have begun to hit the clinicians as well. That we too, are feeling like just cogs in the machine. The meaning is being drained out from us. We're being pushed in ways that make people want to leave healthcare earlier, which is going to be a terrible problem if we, the Affordable Care Act goes forward. We're going to need lots of primary care doctors, and you can't have them all burning out because the system's demanding too much of them. We need to have a cadre of people who can be, spiritually enriched themselves, who are part of healthcare. And so my sense would be that it's doable within 10 years to move from the hospice and palliative care model of an integrated team, which includes spirituality as a dimension of the care for patients who are dying, to spirituality, which is a dimension of the care for all patients. the biopsychosocial spiritual model. What would be the training? The question is, what would be the training requirement for that? Yes, well, it's this I'll borrow from the psychiatrist jokes. How many ethicists does it take to change a light bulb? Just one, but the light bulb has to really want to be changed. A lot of attitude issues that we heard alluded to there are going to need to change. But I think in some ways this is coming from the grassroots. This is coming from the bottom up, this movement. And so I think it's simply going to be that the people who are staunchly resistant to anything, the same people who resisted having ethics in medical schools because it's soft, and didn't like epidemiology because it was soft, are gonna think, but at least at numbers, right? Are going to obviously think that religion and spirituality is soft, and we need to keep that out. But eventually, I think they will become dinosaurs, and there's hunger for this among people, partly because I think practitioners are hitting bottom, just the way, borrowing an AA term, just the way that patients have.
One more question.
Who wants it?
You get it? Okay.
Hi, I'm a student here, a PhD in the religion department, and I'm interested in bioethics. And you talked about healing being, in part, ameliorating divergences from the norm. And I'm wondering if you have any ideas about how we think better about what sorts of divergences from the norm are problematic and should be subject to medicine, and which are workable, and where you think we turn societally for resources for those big sort of worthwhileness questions.
Yes, a very, very, very good question. I mean, medicine is a finite craft, and one of its temptations is to turn, for physicians particularly, to think that MD stands for medical deity, right? And we medicalize everything, right? Everything is our problem. And my mentor, Edmund Pellegrino, wrote about this very presciently in the 1970s, the simultaneous expansion and contraction of the physician's discretionary space, that we were being pushed to be more regulated at the same time that we were having more responsibilities for more and more things. So it's seat belts and nuclear war. They're all part of my responsibility as a physician, and I think that we've got to be more careful about the limits of medicine. One of the places that this has become very significant for me is in ethics, has been thinking about the practice of palliative sedation and the indications for palliative sedation, where there are people who think, well, the goal of medicine is to relieve suffering, right? And if the patient's suffering is spiritual and existential, medicine ought to still be able to do something about it. And what can medicine do? It can snow people, right? Or it can eliminate the sufferer rather than the suffering, if that's the only way that's left to be able to do it. And I think the problem there is a problem with what I've called a failure to recognize one of the canons of therapy, that we ought to think more about what it means for a physician to recognize the sort of rules that govern therapy. And one of those is the canon of discretion. Right? And part of discretion means recognizing the limits of medicine, recognizing your own limits as a practitioner when you need to refer to somebody else, but also recognizing the limits of the craft. And that there are certain occasions of suffering which I would call neurocognitive, and I would include within those things like delirium or depression, which have a biological basis, which I think can be properly considered part of medicine. But there are other kinds of suffering which are what I call agent narrative forms of suffering. Alienation, loneliness, despair, fear, right? If you look up phenobarbital in the physician's desk reference, it does not say that alienation is an indication for lethal doses of phenobarbital, right? So I think it's more questions about what precisely in that area of recognizing that medicine is a finite craft, recognizing its what it means to be in a therapeutic relationship with someone, what are the meta rules that govern that, and among those are the limits, both for the individual practitioner and for the practice as a whole.